Dear colleagues and friends, we have now the Boston Scientific Symposium Innovation in LAAC, and I would like to welcome you to this session and thank again Boston for their support for the meeting and all the discussions that we had. My task is quite easy because I have to highlight the importance of innovation, which is not so hard, and also to support and to introduce excellent speakers. Okay, I will go through this. As you know, AF is a problem and patients are not well treated. Despite LAAC, we still have unmet needs. We don't need to spend time on that. Innovation, yes, we had in the past years. You can see here the first patient was treated in 2001. 22 years later, we have some good devices, new iterations. We also have new generation devices coming, preclinical step at the moment for most of them. But innovation definitely is useful and absolutely mandatory for the future of our patients. Just one word about the factor 11 inhibitors. You all, of course, heard about this, and people said this is the best anticoagulant with no thrombosis and no bleeding. But as you can see, sometimes innovation is not an easy and long, quiet river because the Oceanic AF trial was interrupted 2 months ago because of lack of efficacy of the drug compared to apixaban. So, not always easy to find the good innovation step to be efficacious, efficient, and safe, but what we know is that there is a large room for improvement in our field. All of this could be improved with discussion, with trials, with consensus and innovation. So innovation in LAAC is crucial for a safe and effective stroke prevention. It's timely because the adoption of the procedure is growing in northern countries and is needed to optimize LAAC procedure and minimize complications. Jens-Erik, if you agree, you could present the next presentation, that is innovative solutions to prevent drug-related thrombosis.
Thank you, Philippe. So maybe we can go to my slides. One back. Yeah, I think that the probably most important problem we have with left atrial appendage closure is device-related thrombus. We are putting in a device to prevent stroke, but the device itself can give rise to stroke and result in thromboembolic complications. So this is really something that we should understand and try in every way to prevent. And we have some information about DRT now, especially derived from both the US DRT registry, but also from the European DRT registry. And this is one of the latest review papers that we did with the Mayo Clinic, where we have tried to summarize the knowledge related to DRT. It's something that can occur in 2 to 4% of patients within the first year after left atrial appendage occlusion. High age, female sex, permanent AF, reduced left ventricular function, high CHA2-VASc, coagulopathy, renal disease, deep implants are some of the known risk factors. What is also extremely important is how we look for DRT and how we diagnose DRT, because we don't want to miss DRT and we don't want to overdiagnose DRT, because it can have the consequence that we put frail, bleeding risk patients on all anticoagulation therapy again. So we have to be quite confident that what we see on our imaging follow-up is really DRT. There's now a clear trend for follow-up to be done by cardiac CT instead of TE, and that is more convenient for the patients. But we haven't had a definition or classification for what we see on cardiac CT, and this is work done in our group with Anders Kramer as first author back in a publication in European Heart Journal, Cardiovascular Imaging. And you can see when we look systematic on both the Flex device and the Amulet device with cardiac CT, you will be able to see what we call hyperattenuated thickening. So in the most upper panel, you can see the Flex device. There can be some thickening just around the screw end. This is not DRT. This is because the membrane of the Flex device can lift up a little bit. So that is part of intra-device thrombosis, what we call subfabric hat. Then we can have small regular layerings on the device, which is less than 3 millimeters. We know from animal studies and also from follow-up in humans that that is changes that we see as part of beneficial device healing. We can also see from time to time layerings that are more than 3 millimeters, but if they are still with a very regular surface, and if they are still in continuation with the left atrial wall, we consider this as being part of the healing response. So this is grade 0, the subfabric hat, and grade 1 is changes with a very low likelihood of DRT. On the other hand, we can have more pronounced masses being more than 3 millimeters with an irregular surface, or they can actually be with a pedunculated appearance. This will be grade 2 and with a very high likelihood of representing device-related thrombosis. So we are trying to implement this classification and also in a larger scale of patients trying to evaluate the exact prognostic significance of this morphological appearance on cardiac CT. If we look on the generations of Watchman devices and look at the risk of DRT, I think we clearly learned something from the Watchman 2.5 device. You all know that there was a metallic screw end in contact with blood, and a lot of DRT cases with the 2.5 device was actually located around the screw end. And I think many companies have now taken this lesson, and you will see that they really strive to get at least metal exposure as possible, and this is also the case for the Watchman Flex device. And if you look at the rates of DRT with the Flex device, it is down to 1.8% in the Pinnacle Flex trial. But maybe we can do even better, and that is the thinking behind the new Watchman Flex Pro device, that we still have the same frame, we still have a very low amount of metal exposure to the blood, but here we have also a new coating on the cover that are actually put there in order actively to increase the thromboresistance of this device and fight the risk of DRT. So we have this new fluoropolymer coating on the device. It's non-eluting, it's there, it's extremely stable, it will stay on the fabric material, and that is the most important new feature of the Flex device. Moreover, with the Flex Pro device, we also have now a 40 millimeter device, so we can really close some large appendages. And a new feature is also that you can see that we have radiopaque markers on the shoulders of the device, which make it more easy to actually land the device where we really have planned to land it. It makes it more easy to see the orientation of the device, and it helps to improve deployment of this device. There has been a lot of preclinical work in this new coating, and the concept with this new fluoropolymer is actually that it will bind albumin. It will make a fast, almost instantaneous binding of albumin to the cover of the Watchman Flex frame. And in that way, it will prevent fibrinogen to bind to the surface of the device. And this will result in a lower binding of platelets. This has been documented in animal studies that you get much less acute platelet binding to the surface. It also reduces inflammation. If you implant the Flex Pro and look afterwards on histological specimens, you will find much less inflammation compared to the current Flex device. And in swine studies, there's also an effect on endothelialization. There's a more rapid ingrowth of functional endothelial cells on this new surface. So there's a lot of positive signals, and if you just implant the Flex Pro device in a dog model without any antithrombotic therapy, you will find that this is the upper panel to the left, that the thrombus formation there will be much less pronounced than if you have the conventional Watchman Flex device. So it actually inhibits formation of thrombus on the device, and also if you look at biochemical markers like D-dimer and things like that, there is much less reaction to the Pro device compared to the conventional Flex device. We have had the opportunity to do the first series of 25 Flex Pro devices, and my time is limited, but this is data from the implant here. So you can appreciate the markers on the fluoroscopic appearance on the right-hand angio image. It's useful when you do talking of the device, you can follow if the markers go back in the same position. And you can also, to the right, align the markers so they are completely in one line. That means that you are completely perpendicular to the device, and it becomes more easy to evaluate the degree of shoulder protrusion. And in this very first in-man case, you can see that there is a small inferior shoulder protrusion, but less than 1/3 of the device. This is the appearance of the Flex Pro device on ice, and you can, to the left, actually see the radiopaque markers on ice. You see the white dots there, and the expanded device to the right. And of course, we do all the pass criteria. The frame is the same. And this is the result after 45 days. And there was some kind of layering on the device here. If you can look at the right-hand panel, upper right image, there is a hypoattenuated thickening, but it's totally regular in its surface, and it's in continuation with the LA wall, so this is just beneficial device healing. In the Flex Pro CT study, we also, in selected cases, did MR scan. This is the appearance of MR after 45 days. We can do something called a boost scan, where we look for fresh thrombus. And this is the middle panel, and this area where we have hyperattenuated thickening heads, we don't see any fresh signal from methemoglobin, no signal on the boost scan, and this is telling us that this is not fresh thrombus, but rather device healing. So we already have clinical trial results on the Flex Pro. We have communicated at TCT 2023, our results of the first 25 cases of FlexPro that were implanted with aspirin only and without any DRT at 45 days. We did also do very late imaging, 14 days, 45 days, etc. I haven't time for going into details, but already now we have a large post-market trial going on in US, the HEAL LAA. It started in October and believe before end of 2023 we had more than 500 patients into this registry, which will also be important for us because it will be part of the MDR approval for the device. Watchman Flex and Flex Pro can also be delivered with new curve. We have a fixed curve with a more pronounced anterior bending with improved markers, and we will also have the Watchman steerable sheath coming up. Everything will help us to land the device more optimal. So we have a new fluoropolymer coating, we have radiopaque markers to optimize implantation, we have the expanded range, and we have new tools so we can really land the device optimal and coaxially and avoid leaks. So thank you for your attention. So I think, Philippe, would you like to introduce the next speaker, or we can call on Christoph Hammerstingl. So can you please come, Christoph? We want to hear more about innovation for implanting the Watchman device.
Thank you very much, and thanks for the invitation. I have 5 minutes to talk about how to simplify the procedures, and there are only two aspects I want to highlight. We already talked about the urgent need for pre-procedural planning. I think everybody here agrees, but in general practice, it's not really usual. If you proctoring cases, there are many patients who I see at least where there's the only imaging the patient experiences is the echo on the table, and we should not do it. Ole was able to show how pre-procedural planning with artificial intelligence can help to reduce prognostic relevant complications and improve outcomes. And the importance to make this widely available is to have it not on your computer at home, but to have access, easy access to upload your data, to have it everywhere accessible by use of artificial intelligence. I always want to pronounce that it's really important not to have a software analyzing your images, that you understand why the software comes to the result that is presented to you. But at the end, it can help to make this procedure easier and faster, to increase the capability of your institution to treat more patients in the future if there will be more patients. And I think there's still some room of improvement because what you see are CT scans. In Germany, we do most of our interventions based on 3D echo. Why not do an artificial intelligent approach by use of 3D data sets to come to the same results? That would be the next step, but it's really helpful and good for the patient. As other important aspect, because there are many, every step of the procedure can be refined, but what's very important, of course, is the first procedural step is a transseptal puncture. I think most of you will be familiar with the radiofrequency solution and this VersaCross system. It's not new, but it's available and it's really helpful and easy to use because you have one thing, the radiofrequency wire which have a stiff body, which enables an easy puncture without need to push too hard on the septum, and you can use this wire to introduce the sheath. But here in this with this VersaCross system, you still need to dilate the septum with the transseptal sheath. I don't use the sheath, I just use the dilator just to go over the septum, and this can make the procedure easy and fast. And this has been shown independently in different smaller studies that you can reduce device time, you can reduce the time for transeptal access, and I would say especially in unexperienced centers, it can make the procedure much safer. If you are highly experienced, of course, you can do a transeptal puncture easily, but if you're not so highly experienced, especially with the transeptal access, then it can increase not only or decrease the time, but increase safety and outcomes, of course. And you decrease time because you simply can skip 2 steps of a transeptal access. And the next step in this situation is to combine this transeptal sheath with the procedural sheath. So with your here with the Watchman sheath, with the VasoCross Connect system, you have this shapeable dilator within the double curve sheath, and because it's shapeable and it has a certain stiffness, you can use it for a transeptal access. Of course, it's important that you have a seamless transition because the sheath, of course, is a little bit larger. You have to get through sometimes a septum, fibrous septum, but then you have your device sheath in place and you can complete the procedure. And if you look on the procedural steps, you come down from a needle-based workflow from which in average needs 12 different steps to a 6-step access to the left atrium, which is not only fast, but it's efficacious, it's precise, and it's really safe by the use of a transeptal needle. So to wrap this up, every step of the procedure is important, and innovation can help to improve every step and thereby safety and outcomes. The first and very important aspect of every structural intervention is to understand what you are doing and to plan what you are doing before you go into the cath lab. And one important aspect, of course, the transeptal puncture and radiofrequency puncture is a simple solution to increase precision, safety, and, to my opinion, even outcomes. Thank you very much.
Thank you, Christoph. So, Marek, would you please introduce innovation in the clinical landscape? Thank you.
Yeah, thank you. So within 5 minutes, a few words about some innovation in clinical landscape. So I will start with that, because we are here all experienced operators, but the therapy awareness among, let's say, general cardiologists, and moreover, among other physicians is low or extremely low. So the initiative, which I had the pleasure to lead with John Kemp, was to just to get experts from different fields from the whole internal medicine, so nephrologists, gastroenterologists, general physicians, and we prepared a practical guide which is intended not for the implanting physician, but for non-implanters. And that paper has been just published just 2 days ago. So, and it's a paper in which you first think for which patients that LA closure should be considered. And in fact, the particular parts of the documents were written by the specialists in different fields. And the plan is that also the smaller documents extracting a part of this document will be published in separate journals for nephrologists, gastroenterologists, and so on, so on. And we are thinking also about, let's say, the shortest version of that document for the referring physician, just published in national languages in every country which will be interested in. And we hope that thanks to that, the knowledge about that therapy will be more spread among, let's say, other specialties, not only electrophysiologists or interventional cardiologists. Then, when we talk about the expanding indications, we have heard about the trials which are now ongoing. So first trials in which LAA closure is tried against oral anticoagulants. However, soon in Europe, another trial will start, as a trial quite similar to LAAC. First enrollments were done in Canada in December, and we hope that the trial will be soon in Europe. So not only in patients like we treated now, so low or moderate bleeding risk and moderate or high-risk stroke, but really in patients with high-risk stroke and especially after previous incidents. Option trial, the results will be at the end of that year, and we hope, and I strongly believe that with that results of that trial, there will be a new indication. So patients after ablation will have a choice. Will I want to continue with the drugs, or maybe the LAA closure is a procedure for me, not only as a concomitant procedure during ablation, because then you will limit that strategy only to electrophysiologists, but also as a subsequent procedure, because in that trial that option was tested as well. Of course, these two trials are crucial. Champion finished enrollment, and we expect the data in 2025. Catalyst, as far as I know, is still ongoing with the enrollment, so it's slightly behind. But with the results of these two trials, we will have the answer about the potential alternative to oral anticoagulants. And the LAAC trial, which I mentioned before, based on LAAC, with randomization to OAC only, or Watchman Flex or Flex Pro, when it will be available in Europe, with oral anticoagulants. And in Europe, probably it will start about summer. And we hope that we will be able to replicate the results as our colleagues, cardiac surgeons. And there are also some other trials, upcoming investigator-sponsored trial. I am showing just two of them. One, a LAAPS trial, so with randomization to quite similar, in fact, to LAAC. So DOAC versus LAA closure plus DOAC. And based on the ADALA trial, also maybe we should change our way of thinking about the treatment after LAA closure. So maybe that very attractive idea of giving, let's say, half dose DOAC will be something which will be a new way of thinking and new way of treating of our patients. Thank you very much.
Thank you, Marek, Jens Erik, and Christoph for this great talk. To conclude, I would say that innovation, of course, is part of the game, and we are waiting for the result of the trials. We are waiting for the new iterations of the devices and efficient and safe post-procedural treatment. Thank you all, and thank you again for being there for the symposium. We are going now to present the result of a survey. You have the slides, please. So the idea with this presentation is to discuss what we do in Europe in 2022, 2023, in terms of practice in the field of left atrial appendage closure. So this is a description of current practice with a close focus on pre-procedural planning, but also procedure techniques and post-implantation management. The This is a non-funded international multi-center observational study that was conducted between March and August 2023, consisting on almost 50 multiple choice questions on current practice in the previous year, in 2022. So the main areas you will see with the result is patient pathway, pre-procedural planning, LAAC procedure, and post-procedure treatment and surveillance. So these are the results and the regions in Europe. You can see we had results of 357 centers from 14 countries and treating almost 9,500 patients with left atrial appendage closure. For geographical reason, we mixed the countries as countries from Central Europe. You can see here, this is mostly Germany, Switzerland, Austria, and Poland. Countries from Southern Europe, mostly Spain, Italy, and Greece. Northwestern Europe is France, UK, and Belgium, and northern countries, Denmark, Norway, Finland, and Lithuania. So if you look at the first slide, this slide, you can see that in terms of adoption, the result is not the same in all regions, geographical regions. You can see that there is a quite 3 times difference between the Central Europe and the Northwestern Europe in terms of adoption in number of procedures per million inhabitants. So if you look at the number of procedures per center and per European regions, you can see here that the average number of LAAC cases per center was 26 in a year, which is quite low in Europe. The median, you can see, is 20 with a quartile range of 10 to 35. And if you look in the right panel in colors, in Central Europe, Southern Europe, Northern and Northwestern Europe, you can see here the median is 21 in Central, 16 in Southern Europe, 29 in Northern Europe, and 25 in Northwestern Europe. So it's quite the same in all the areas of Europe with a quite low number of procedures per center and per year. Now, if you look at this, you can see that 1/3 of centers declared having difficulties to increase the number of procedures. And if you look at the main reason, you can see that the most important was the presence, the lack of presence of the anesthesiologist in their cath lab, or the low availability of the cath lab or hybrid room, or because we are missing beds for patients, we are also lack of availability of imagers and nurses, and finally operators. And if you look at the different regions, you can see that it's absolutely not the same across the European regions. You see in Northern Europe, happy countries, they have only 11 problems to increase the number of procedures, 11%. Central Europe, 26, Southern 40, and Northwestern Europe is 50%, 49%. So it's not the same problem in all these geographic areas. If you look at patient pathway in Europe, you can see that most of patients are from in-hospital, 76%, 21% out of hospital, and only 3% with both recruitment. And if you look at the distribution in the geographic areas, you can see that it's not the same in all countries, with more patients from in-hospital in Northern Europe and more patients from out of hospital in Northwestern and Central Europe. If we look now at the referring physician specialty, you can see here that the most important is cardiologist in only 26% of centers. We also have gastroenterologists, 19%, neurologists, 20%, nephrologists and urologists in 15%, internists and geriatrists in 19%, which is quite well balanced among regions if you look at the right panel of the slide. If we now look at the pre-procedure planning and imaging modality in terms of percent of centers, you can see that the pre-procedure planning is done in Europe with TEE in 62% of centers, TEE only 62%, TEE mostly you have to add 10%, CT only 16%, which is more or less the same than in the US in the NCDR registry that you showed previously. And you can add 12% of centers doing CT mostly, meaning not all the patients, but for most of the patients. Very interesting if you look at the distribution in the different geographic areas. You can see that in Central Europe, and mostly in Germany, TEE is the preferred option for planning, 88%. And you can see the difference. In Northern Europe, you have CT with 78% of centers using CT only to plan the procedure. I would say that in Southern Europe and Northwestern Europe, it's more or less 50-50. But there are really, really very important variations among countries and among European regions for pre-procedure planning. Very important to look at this. If you look at what was the pre-procedure planning done by the implanter or by the imager, it's not the same. You can see that in CT centers users, the implanter has done his planning in 85% of cases. In TEE centers, the implanter is doing his own planning in only 58% of patients, meaning that you rely on the data of the imager, which is okay. But I mean, what we want to show there is that possibly CT user centers may be more involved in terms of implanters in the procedure, and possibly this is one of the explanations of the different results that we observe in these trials, showing that if you are aware of the CT, you don't have the same procedure result at the end. You can see the distribution of tools for planning. Most of them are dedicated LAA software or DICOM software, and very few use CAST lab or external simulation softwares. So what about the procedure? If we look at the implanter team and the theater, you see that the implanter team in Europe is IC, interventional cardiologist, in 3/4 of centers. EP 13%, a combination, a team in 11%, and there are few centers with pediatrician. The theater is the cath lab in 84% of centers. Hybrid room only 16%, so it's really very few centers. If we look at the imaging modality for procedural guidance, you can see that standard TE is the most frequently used option, 89%, ICE in 5%, micro TE or mini TE in 4%, and fusion CT and fluoro in 2%. And again, there is a huge difference between geographical regions. If you look at Central Europe, TE, the same standard TE is the solution, the option in almost all centers. And again, Northern Europe, they are showing the way with the ICE. CT plus ICE is the good combinations for their centers, because they are using ICE in 36% of centers. In Northwestern and Southern Europe, TE in more than 80% of centers. Non-surprisingly, if you look at the type of anesthesia, we have 50% of general anesthesia in Europe, 1/3 of conscious sedation, and 16% centers using ICE. with local anesthesia. This is what you can see on the right panel. You can see that most centers of Northern Europe, they are using conscious sedation or local anesthesia because of HICE. And in Central Europe, you may have general anesthesia or sedation with TEE guidance for the procedure. So what about some procedural characteristics? You see that invasive blood pressure monitoring in 42% of centers, echo-guided femoral vein punction in 47% of centers. Most centers use unfractionated heparin in 94% of centers. The type of heparin injection, time for injection, is full dose after transeptal puncture in 52%, 50-50 in 40%, and only 8% injecting all the heparin before transeptal puncture. ACT is used systematically in 61% of centers, only in case of complex and prolonged case, 28%, and never 11%. If we look at the transeptal material, you can see that most of the centers use a classic needle, 87% of centers, a radiofrequency needle in 7%, and a classic needle plus electro core 3 in 5%, and radiofrequency wire in 1%. So the approach to LAA and selective injection, you can see here that 49% of centers use a pigtail, 41% is approaching the LAA with the device, and 10% with the delivery sheath. Selective injection is used systematically in 62% of centers. Complex cases, only 18% of centers, and never in 20%. 20% never injecting the LAA. Injection of the LAA can be done with the pigtail, 60%, delivery sheath, 14%, transeptal sheath, 6%, and no injection, 20%. If you look now at the hospital duration, you can see here that 72% of patients are discharged on day one. So 3/4 of the patients spend one night in the hospital and then discharge. 6% same-day discharge procedure, and 22% are discharged beyond one day. Only 16% of center could consider same-day discharge for selected cases. So meaning that we have some limitations or restrictions to increase the number of same-day discharge procedure. And if you look at the main reasons for that, you have general anesthesia in 59% of centers. You have reimbursement concerns in 29% of centers, and probably a higher rate of this. You have, because it's a risky procedure, only 2%, patient's frailty, patient's profile in 2%, other reasons 8%. So most of these are general anesthesia, which is not the same in patients with surgery and same-day discharge procedures. So we have to reconsider maybe with new data on that, the very good reason to have patients in the hospital. If you look now at the post-implantation standard antithrombotic therapy, you can see that in Europe, DAPT is the routine treatment in 3/4 of centers. Single antiplatelet therapy, 18%. Oral anticoagulant, 7%, which is not surprising because we do the procedure for patients at contraindication for these drugs. We have 1% of centers using non-antithrombotic drug as a routine procedure, and we have 1% of centers using OAC half dose as a routine procedure. And if you look at the difference between regions, you can clearly see that there are major differences, especially between Central Europe, Northern Europe, and Northwestern Europe. The mean duration of standard antithrombotic therapy, you can see that in most cases it's between 6 weeks and 3 months, 80%. Only few percent of centers using antithrombotic therapy up to 6 months or beyond, and only 1% using less than 6 week antithrombotic duration. If we look now at the imaging modality for post-intervention surveillance, you can see that, again, TEE is the leader. 71% of centers using TEE at follow-up to have follow-up imaging of the procedures. TTE is used in 16%, CT in only 12%, and fluoro for 1%. Again, if you look the difference between geographic regions, you can see that there are completely different distributions, especially between Central Europe, Northwestern Europe, and Northern Europe, using mostly CT to follow their patients. So to summarize, the key findings of this survey is that you can see that half of centers performed less than 20 left atrial appendage closure cases per year, which is quite low, especially comparing with what is observed today in the US. The pre-procedure planning was more frequently performed by TEE in 72% of centers, and when performed in CT centers was most frequently performed by the implanter using dedicated LAA applications or viewers. Left atrial appendage closure procedures were mainly performed in the cath lab, 84% of centers, under general anesthesia, 50%, and standard TEE was the most frequent imaging modality to guide the procedure, 89%. Far ahead, ICE, 5%, or micro-TEE, 4%. The standard post-implantation drug regimen was DAPT in 73% of centers, maintained for 6 weeks to 3 months, and then followed by SAPT. And finally, TEE was the main technique used for follow-up imaging in 71% of centers. Of course, there are limitations. Of course, the survey is not exhaustive, although it is one of the largest ever in Europe. You can see that what is estimated, especially by the market-derived data, is that there are not 10,000, but 12 to 15,000 patients treated per year in Europe. No 357 centers, but approximately 500 centers, and probably 20 countries are proposing the procedure. So we are not far from exhaustivity, but it's quite good. So to conclude, LAAC has become a widespread procedure in Europe. There is a great heterogeneity, of course, among European regions in terms of pre-procedural planning, procedural techniques, guidance, and post-procedural antithrombotic regimen and surveillance. We hope that the guidelines might be updated with the results of pivotal trials that we just talked about, with an increasing number of procedures, centers, and physicians. And we think that there is a need to homogenize practices. Thank you. Ole.
Yes, I don't know if any comments or questions about the data. First, great data, Philippe. But you see it's very variable what the approaches are in Europe. And that's the whole question. Are we ever going to be able to standardize that? I'm not sure. I mean, if you see how different it is, or like there's many constraints from reimbursement standpoint of view, if you look, for example, to Germany, or I compare to the Nordics, so I'm not sure if this could be a goal to standardize. I don't know. What's the opinion here in the room? If there's any, should we strive for that? Is that the goal of LA Club as well? Yeah, maybe Marek.
Just one question, because asking about what are the limitations in center to increase the number, I can't remember. There was a question that, or the answer, possible answer, lack of patience, because I do not believe that it's impossible to manage more than 20 patients in 1 year in one cath lab. Yeah, it's not because of anesthesia, lack of, let's say, access to the room or hybrid room, since majority of the cases are done in the cath lab. Yeah, so probably the lack of patients is the main driver that there are centers doing less than 20 procedures per year.
Yeah, lack of referrals. I mean, it's therapy awareness. There's you don't get the referrals. I mean, not everybody gets the patients floating to a center. Yes? So I think that could be a limitation. Reimbursement limitations, for sure. There are reimbursement limitations in some countries. I mean, there's so many constraints. Yes? So, but cath lab time could still be a problem. I mean, if you do 20 and you suddenly have to go to 50, could be for some cath labs, could be an issue. I mean,
or anesthetists or nurses,
absolutely,
hospital organizations.
Mm-hmm.
I was also a bit puzzled by the last sentence. So, why would you think, Philippe, that it is necessary to homogenize practices? Shouldn't we more focus on outcomes? I mean, if you look at, for example, TAVI, again, I bring it up, there are still centers that do TAVI in general anesthesia with TE guidance. Now in TAVI, it has become more minimalistic approach in many other centers. And I think at the end of the day, what counts is the outcome. So why do you feel a need to homogenize practices?
I think the example of TAVI is absolutely appropriate, because if you remember the beginning of TAVI, we were just sizing the LVOT with TEE in a patients with general anesthesia. I remember that. And we didn't have the 3D capabilities at this time. And progressively, we increased the quality, we decreased the complications, increased the quality of procedures with CT that became the standard. But we are not there with left atrial appendage closure. We have only 16% of centers using CT. So the other one are doing 3D TE, and that's okay. But if you have a 3D imaging to plan the procedure, that's okay. So what I mean, that was a little bit provocative, but I wanted this interaction, that's why. But I think we should not all use eyes, for example. We should not all use, I don't know, mini probes or something like that. We have to use what is needed, what is best for our centers, because we have all different limitations, different restrictions. But at the end, we have to find the minimum required to have a good implantation. So don't do it alone. Do it with good planning. Do it with 3D imaging capacities. Do it in the centers with high volume, good safety, something like that. This is, I think, what we should have as a focus.
I would like to challenge that a bit, because you know, if you have in your center someone like Nina Wunderlich or Becky Hahn, so why do you need a CT if you do LAAC closure? Or for example, my personal experience is, and how I do the procedure is just only fluoro-based. So no CT, no TEE. And I mean, at the end of the day, you can say, as long as the outcome is good, then what's the point? And at one point, I think we shouldn't be too pushy. We should just give guidelines and saying, hey, look, these are important points to look at. How you get there is actually should be more individualized. It's the same as with also a PCI, for example.
No, true. I think by time I also agree that you cannot force a certain approach to some centers or some countries. I mean, you have to see in what context you have to work. And you can come with some recommendations, but I think I will show that I have just 2 slides to show, but I think we should go away to try to homogenize everything. It's simply impossible. I mean, there are limitations, there are contexts where people work in. But then, for example, if people work not with CT and with TE, I think you could make a contemporary recommendation could be, use then your 3D function of your TE. Don't do it on the classical 0, 45, 90, 135 measurement only. You can make, I think if you have a good, proper echo imager in your center, they can make multiplane reconstruction imaging, and I think you should move to that kind of recommendations, specific for, do it at the best you can with the tools you have, and that's it. But you can indeed not force and say, I think that's what I believed 10 years ago, that it was going to go maybe in the direction everybody CT pre-procedural planning. I still personally think it gives some additional value, but okay, many sites prove that it's possible to do without and to obtain good results, so you have to respect that too. So I think I can also understand your vision too there. And I think that's a thing what we discussed up front. What should be the goal? And then maybe I can have my slides up, because that's a little bit what should be the goal of that, of the European LAA closure club. So maybe I can have the slides up. Yeah, or a comment.
Just a short comment. I mean, nothing speaks against recommendations, and of course we appreciate that some have particular experience with that and that imaging method, and if it's angio-based and you have large experience, that's fine, but we have to come up with certain recommendations for the common user, let's say, but that's not what I wanted to point to. But the key issue there, I think, in this survey is that there is a huge heterogeneity, which is the expression of lack of data. If you consider not the imaging, but the post-procedural antithrombotic therapy, I mean, there's absolutely no reason to believe that all these 10 regimens are equally efficacious and safe. It's just the expression that we don't know. And this is a true call for more data, and the registry is one way, and the better way is potentially RCTs in the field. But this really expresses that we don't know enough on the topic.
I agree, and I think that's a little bit the problem with the field of LAA closure. I mean, we're out of our cocoon of like implanters. We're not taken very seriously. I mean, go to a neurology meeting or gastroenterologist. I mean, you're such a bit orphan, like the weirdo who does LAA closure. So why is that? Because you don't have proper data, no? And that's true. So we are missing good data, good evidence. Everybody does a little bit his own approach, and that's why the field is also not taken 100% serious by many. And that's also true. And that's a bit I think if we can get the slides up then, I mean, I think that's kind of a little bit the goal of the LAA club to indeed, how can we push this field more, that we're taken more serious? I think, let's be honest, that it is like that we're not taken very, very serious out of our own field. So first thing is, I have only 2 slides. I won't exhaust you now here at the end of this day, just 10 minutes maybe. But where are we heading to in the LAA closure field, and what can be the role of this ELAACC, there's missing a C, the club. So where are we heading to in the LAA closure field? And I'm not standing here to postulate some opinions of me, but it's more open questions, as you see. So increase in volume, exponential growth, can we really expect this, yes or no? I think we could probably anticipate this if some of the trials, like Champion AF, Catalyst, Option AF, if these trials turn out to be positive, it could be that in a couple of years from now, we indeed have to prepare for an exponential growth. And then the question, and that's indeed expansion of indications with these trials coming up, I think it's very important. And then the question is going to be, how are we going to deal with these increasing procedural volumes logistically? But also operators, who will be performing LAA closure? And I think the majority of, or almost everybody here, are interventional cardiologists. Are there any EPs, electrophysiologists? 1, yeah. Well, look, so, okay. But the question is going to be, are you open in your center? I mean, if let's let's maybe turn the lights on. It's better to have a discussion. So if option AF turns out to be positive, so that's the trial where they do an ablation. Yes, it's mostly cryoablation, and then they do the LA closure afterwards, or they can do it at the same time too. Yes, but if that trial turns out to be positive, I mean, maybe many of your electrophysiologists in your center will be tempted to start offering this therapy to your patients too. So I want to hear, what's the opinion? I mean, do you feel threatened, or how do you see that? Do you think you're ready to give that whole field to your electrophysiologist, or will there be a battle for that? Or I want to hear some opinions about this. How do you see that?
Yeah, well, I think that it's just expanding indications. In my center, electrophysiologists are not seeing that therapy almost at all, only for the contraindicated patients. But now, after, let's say, when the option would be positive, then maybe for them it would be interesting. I will do an AF ablation and finish with the LA closure. Probably at the beginning with my help, but later on alone. And I do not think that we will fight for the same patients. It rather will be new patients coming to the field.
So he will be more tackling these patients who have more the arrhythmogenic problem, and you will be tackling more the patients who have like a stroke or bleeding problem, and not really so much the AFib problem. It's like patients with persistent, permanent AFib, and you think you can cohabitate together? Like
I believe so. I believe so.
Other opinions? Yeah, other opinions here? Yeah.
I think, and I'm interested in your opinion, in that in centers in which there are the structural valve procedure, usually the interventional cardiologist is more interested in this procedure than the electrophysiologist usually performs the LAA closure. In the centers without this facility, usually is the interventional.
Yeah. Fabian, you have like
in my center, there are electrophysiologists doing it, and I'm doing it. So I think there is enough for all. And the more that are doing it, the more the procedure is performed. We all believe in the procedure, so we should actually advocate the electrophysiologists to do it. We shouldn't be afraid that we get less. I think we all get more to do, and specifically the patients get more LAAs closed, so I think it's a good thing.
Yeah, personally I think so too. I mean, you don't have to see it as a competition. I think it's only, typically if it's 1 and 1 gives probably 3 here. It's more the therapy gets more awareness in the hospital or in the region, and probably it's turning out more like that, yeah.
And what about the procedure time? Do you have any idea on that? Because if you, like, for example, combine TAVI with LAA closure, sometimes it can increase the procedure duration, no?
Yeah, I agree. We've been doing a couple of these cases, and I think for these elderly patients, having a TAVI first, which takes 45 minutes, and then still adding there an LA, which you never know up front. It can be a half-hour quick fix, but it can be an hour case too. It's too much for these old patients. But on the other hand, these ablations, they are turning into procedures of just 25 minutes. So it's kind of an easy fix too, and you're in the left atrium there anyway, yes? So, and Erik, yeah?
No, I really believe that in the future it will be combined ablation LAAC procedures. I mean, for ablation, first of all, this field is changing enormously. Now you have pulse field ablation, which is a very, very appealing technology, not creating edema, not changing tissue structure, etc., done very easily. And before your ablation procedure, you have all the imaging, you have the pulmonary vein imaging, you have the LAA imaging, and doing LAAC as an extra, it's a question about 10 minutes and not more.
So therefore, you will be doing it, or your EP colleague will be doing it?
We were part of the option trial, and we had it as a teamwork, so the EPs called for me, and I read their CT scan, and it took me 10 minutes more, and I could do the procedure. But I mean, in the long run, that will not be like this. There will be one guy at the table treating the symptoms of AF and treating the problem related to thromboembolic complications. Yeah. And I mean, electrophysiology, that's also something else today. It's not about sitting and measuring intervals and spikes and everything. It's so much resembling what we are doing as interventional cardiologists, steering around with quite large sheets and targeting anatomical structures, looking at 3D imaging and things. So it could be both an EP, it could also be an IC that are going to do those procedures, but it will be combined procedures in, I believe, near future.
Sorry. I think that in the combined procedure, I think it's very important for the pre-evaluation and, for example, the transeptal puncture. The EP cross whenever they want. They don't even care where they cross. But if you are planning to do a combined procedure, they will need to evaluate the CT scan, plan the transeptal function, which means I don't think it's going to be a procedure on the way. If you're on the left atrium, just put the LA occluder, but maybe we need to change it and sit together with them before. Fortunately, sometimes we have to do it, and plan the combined procedure, and not just on the road to put the device there.
Pre-plan it as well and take it into account, yeah?
Yes, yes, I have a special word. No, I think there are several technical considerations for electrophysiologists that will have a longer way to reach the skill, longer than IC guys like you. But of course, it's possible. And I worked with Philippe 10 years ago, and I had to improve my way to use the material and everything. And I think it's a complement to our practice. But in your practice is more like an usual thing. That's the first thing I wanted to say. So before that, EP teams could close the appendage just after the ablation. I think we have to wait for many years in terms of skilling for EP people. But just find a device that you can see in the 3D mapping, and then everything will be very, very fast for us.
Take it. I give this to you, and you give this to him.
Okay. Just one comment. What you said is true, because I proctored some EP guys, and it was always hard to convince them that they have to do the transeptal puncture where we want them to puncture, not where they are used to do it. But from a patient center point of view, it makes totally sense, because you get rid of AF and you can get rid of the oral anticoagulant. So it's a really smart approach.
I think it's very important what Fabian said. To bring the technology forward, we have to get more people doing the procedures, and it's very obvious that it makes sense to occlude the LAA after a PVI. It has become so fast, and we invited one of the EP consultants at our hospital 4 years ago to join the LAA team, and now it's a team. Sometimes we help them, but they are now reached after 3-4 years independence, and it's clear that the field will change and that more and more patients will request LAA immediately at the time point of PVI. But this is not harmful to us. This will help to really, to make the intervention well accepted by the EP community, which I perceive is not yet the case in Europe.
Yeah. No, I think so indeed. That's why I said I think it's more 1 + 1 will be 3. It will help to get more support for the therapy, awareness, and etc. To move on, do we need standardization, or can we live with different methodologies? That was the thing. So in the preparation of this club meeting, there was a lot of repetition of like, yeah, this field is missing standardization, it should be much more, it should be one standard. Yeah, I see the pros and cons. I mean, I said also, because there's so many ways, and also, for example, the post-procedural treatment, it can't be that all of these differences are as good for the patient. So that's why our field is also not taken fully serious. So we need some standardization, but we also have to accept, especially some technical points, that some do TE, others ICE, others CT, TEE. But if you do it, then do it the best way you can. And that there can still be recommendations on that from this kind of initiatives to come with recommendations how to do it contemporary in the best possible way. But I think we have to give up on the idea that we can force one standardization in entire world or entire of Europe. That will simply not work. And then that's another thing I want to throw into the group. Do we need more or just less advanced imaging? Of course, it's very tempting in a group like this with experts and specialists. It's like geeks, yes, you go into the nerdy thing and new tools and new technologies, but you also have to be aware that if you do that, then maybe you scare off a lot of people from the therapy, or they think like, oh, that's not for me, or it can also keep your field limited. So instead of going to more and more advanced imaging, it could indeed also be sometimes good to go to more simplified if you can get the same outcome with a more simplified approach. I don't say which simplified approach. It should be then, I think CT could still be a key, because then you can keep your procedure like super simple, super slick, very easy, but that could be an open discussion.
But so, Ole, what about if you just go and get your LAAC close without any screening, because you in the lab are going to have a 3D imaging without general anesthesia, and you have on your shelves all the devices. So I mean, the pre-planning that you're doing, maybe 10 minutes before the case, you are doing the case. So maybe, you know, like if there's no general anesthesia, same day discharge, and there's no, I really like the pre-planning, but that I like pre-planning doesn't mean that the planning cannot be done, you know, in the table, plus you have the LA pressure. No. So now with a, well, Laura will talk tomorrow about that, but now with a mini 3D, so you can have all this. You have like 3D imaging assessment, so you don't need general anesthesia. You can do the same day discharge, and if you have all the devices available, I mean, you're not going to skip anything, and you're not going to, you know, cancel the case just to implant another device. So, I mean, that's possible now. And I was like always, you know, promoting the pre-procedural planning, but maybe it can be done always. That's the point.
Yeah. I can understand both opinions, but yeah, Jens-Erik?
Yeah, I have really difficulties in understanding this resistance against pre-procedural planning by cardiac CT. I mean, it has been almost 100% implemented for TAVI. The aortic route, simple structure, it can be circular, it can be oval, but you are measuring and understanding this structure in 3 dimensions. And why? Because you want to avoid leaks with your TAVI valve, because that has some unwanted effects, and it's totally the same with LAA, except it's just a much more complex structure. The ostium, the landing zone, can be completely different, and we want to avoid leaks with this procedure. So we should understand this structure in 3 dimensions. I mean, it's the only way forward. We will never get rid of leaks if we don't use imaging to understand what's going on. And also the follow-up that we do now with TE, I think it's too primitive, because some are very good TE imagers and pay attention to what is really the mechanism. Is it a missed lobe or something? But if you look into the literature, it's just about measuring the width of a peri-device leak, and it's very, very simple, I think, and it's not sufficient. So I cannot understand this resistance.
No.
Well, just to answer that, in our hospital we used to do TOE for planification. Now, as I will show tomorrow, we skip for some patients the planification. But the good thing about the TOE is that you will have the same imaging that during the intervention, and plus, if you do it with 3D imaging during the implantation, all the measurements, you are sure that the left atrial appendage have full of volume. So you are sure that you have the right volume inside the body to make the accurate measurements. The thing is that you need to do in 3D, and the measurements, if you have a nice visualization that is most of the patients, you can do a very reliable measurements of the ostium and the landing zone. So it's something that for me the TOE makes sense. Even in our center, the TOE for planning, it's performed also for people that don't go to the cath lab, but you have the 3D volume. So I used to do all the measurements before to go to the cath lab. It don't depend on me because it's just to get a 3D, and it's more or less so easy as in a CT to do with the previous. And the other thing is that a lot of these patients have impairment of the renal function, or they are very old. So you are putting a lot of contrast during the CT. So it's something that you can skip. So you can do a full intervention without any contrast, not in the planning, and also during the intervention, if you do with 3D, you can also do it without any contrast, so it's safer for your patient. So it's something that I think it depends on the country and in the center, because maybe in some centers they are not so involved in the TOE, but it's something that can be done and it's safe, I think.
Yeah, Adele, and then maybe it's appropriate that
Yeah, sure. So I mean, I think one lesson from the presentation of Philippe, the discrepancies between the countries, I think it's also linked to the reimbursement issue. And from countries to countries, for example, I know in Germany, for example, CT is not reimbursed, so they will not use it. In my lab, for example, I would love to use ICE, but I have to pay a lot of money for that, so I cannot use ICE. So, I mean, many of these differences are due to reimbursement. So what we can do as a group, we first need to accept that nobody will do the same because of the difference in availability and so on. But what we can do is to give some guidelines about what we think is the best, and also that can promote reimbursement in the future in many countries and things like that. For example, if you use 3D imaging, for example, 3D imaging, just if you have only TE or CT, use 3D imaging. It's obvious for CT, but for TE, it's better. If you use what you say, you have some guidelines to what to look for during the case, the pressure, the things, and the volume, and everything, and so on. And if you use ICE, for example, we know that people using ICE, they're strongly advised to have a CT or a 3D imaging before. So for each kind of modality with differences, you need to have strong guidelines on how best to use it, actually. Because nobody has always Nina Wunderlich in the lab.
Yeah, I completely agree with Erik. I mean, we definitely need to know the exact anatomy, but I think, and coming back to you, what you said, Laura, I think this is also important because if we use the same imaging modality pre and post, we know exactly what the mechanism is, why we create a leak or why it's happening, because you see pectinates. I mean, you have to be active. Active imaging, I think, is the most important thing during the procedure. And you just have to be confident with the imaging modality you use. I mean, if you have a really good 3D understanding, use CT in advance, implement it during the procedure with ICE, everything is fine. The only thing is, it should be clear that we really address the anatomy of the patient. However you do it. I mean, I feel confident with TE. Erik feels confident with ICE. That's fine, I think.
Last one, Fabian.
Yeah. I love when people are enthusiastic about something. So now I learned that Jan-Erik is very enthusiastic about the CT. Nina is very enthusiastic about using TEE. I'm very enthusiastic about using nothing. And so at the end of the day, I think I would not try to implement my way on someone else. The only thing I ask for is let people do it the way they're most comfortable with. And then you can start comparing outcomes. So just data now being analyzed, and the manuscript is submitted, where we compare 400 patients treated with fluoro alone and compared to TEE. No differences in hard endpoints, and no differences in procedural outcome. Not published yet, but submitted. So I think that's what we should strive for. You know, allow everything that people want to do, but then you should also obviously show that it works?
Yeah, I think that the comparison with the TAVR field is really sound, and I was younger and I witnessed the beginning of the TAVR, and at this time, like 15 years ago, a good outcome was just the valve in position and without any consideration for potential leak and whatever. So if the patient was alive at the end of the procedure with a small gradient, everybody was happy. Also because the patient was very sick patient with contraindication to anything. And then we realized that paravalvular leaks were an issue. And so we improved our practice in order to get a better result. And now a better result is just not the position of the valve, no embolization, of course, but also the absence of any significant leak. And now, as we are treating more younger and younger patients with TAVR, we realize that our aim is also to get a proper durability of the valve, so getting good hemodynamics. And so I just mean that our aims evolved over the past 15 years as we treated younger and younger patients. So if our... No, the question is, no, I think that potentially our aim, where are we heading in the LAA closure field? Hopefully, maybe in 10 years, 15 years, that will be a first option for treatment of patients with atrial fibrillation, in which we don't want to propose oral anticoagulation. So in this perspective, we have to provide a therapy that will long for years and years, and probably 10, 20, 30 years. Yep. And so we have to get the best result possible, the best possible result.
Okay, I think I'm gonna have to kind of, an absolute last, really short.
No,
yes,
just one short comment. We have heard very expert echographer saying that echo is a must. I definitely agree that we can do everything with echo, and it's very good. My echographer that I trusted left to Switzerland. Now she works with Lawrence Weber. Congratulations. So now I'm alone. I have a new echographer, but they have to train, and I was very happy to really master CT scan. So my feeling is that if you really want to be an independent operator, you need to have your own way of imaging. You cannot only trust an echographer.
Okay, absolute final one, short.
I think actually none of the opinions should matter. We should just find the data, and if we look at Predict LAA, where we see that excellent pre-procedural planning being done by experienced operators is already trumped by AI looking at the same images, then I think we should move away from saying, but we're very good at this technique, we're very good at that technique. We should take into account the context of a country, the reimbursement criteria, but I think we should still look at objective data to define which is the best pre-procedural planning techniques.
Yeah, I think, let me conclude with, you see all the discussion that fuels extra the need for data, evidence, research. And the last thing, it's also, maybe we're talking a lot about all the imaging. The thing we're maybe just missing is just good devices, you know. The devices we have are maybe just, they're okay, but they're also not super, let's be honest. They don't close our LAA completely in 100%. So maybe these devices just have to become better. So that's the final comment. So that's, I hope the companies heard that. No, so then this one, because we have really short time, I think we have only 5 to 10 minutes. So this is maybe more with a raising of hands, yes or no. I think what I was, the whole idea of this LA club, I was thinking, okay, and many ideas were formed there, which are all great, but you can maybe not tackle them all. So what do you expect from the ELAACC? What do you want us to prioritize? Or what do you, if you come to such a meeting, what do you really think is important, or what do you want to get out of it? So maybe just quick by raising hand, the research database that was discussed in the beginning, is this something that is maybe just important for the people who started with this idea of the LA Club, or are there other people in this audience who think, no, this is also really something, but if I come to such a club meeting, I want to get participating in this and want to get something out of that too. So for who is this important? Yeah, okay, so that's the majority. So that's well assessed by that it's important, and that's an initiative. That means it's encouraging to move on with this, yes? And I think the practicalities, maybe I think that has to be discussed tomorrow, because many people will go home tomorrow and they will think like, yeah, I want to participate in this, but something has to be set there how this practically will go. If they can say, I'm interested, that they get a link to get into the REDCap database or something, there has to follow something concrete out of this. Then consensus papers, as you saw, the Bifurcation Club does it really nice. They come almost yearly with a consensus paper, publish a your intervention. Is this something you think could be of value? Is this the task of this club? Yes or no? Who thinks this is the task of this club and would think this is interesting? Slightly less, but still it's around 70, 75, 80% of patients, not patients, people. Yeah, too much in the hospital. Yeah. It's like sometimes if I go on vacation and I say I have to go to, let's go to the hotel, let's go to the hospital, and it's like, oh no, let's go to the hotel. That's too much work. Or who thinks, now this first day, it was a lot about this research database. We spent a lot, and I think we needed to spend a lot of time on it because it was really the kickoff. That shouldn't be repeated every time. Probably, hopefully then the next time or next session, it's more about which ideas, which research ideas should we initiate based on the database where there's then by then next year maybe hopefully already 2,000 patients or something. But who thinks if they come to here they want to, just because it's a group, limited group of experts, it's a lot about case and experience sharing, like one case after the other, difficult cases, sharing how you tackled it. Is that something what somebody expects from this kind of meeting or not? Who expects this to find this meeting? Not many, actually, surprising. I thought many would also expect that, but apparently not. So, okay, that's good to know. Then, yeah, I already got a comment anonymously, like, yeah, it's not very happy with that name club. You know, it sounds a little bit too exclusive, too limited on invitation only. There was some negative, there's some negative context about that club. It's not because the European Bifurcation Club does it that way, that we should completely copy-paste that, despite the fact that they're very successful. Is this something, something that's people think, yeah, it should not be called like a club, it's too scaring off, or is that just perceived as something positive?
So what's the if it's a club which that means
Sorry, that it's? Yeah, but that's another thing. So engaging other disciplines, I think now it's, for my taste, too exclusive, to be honest. You know, it's that's not good neither, because then you keep on turning in circles after your own tail, and you can say how great you are doing every year, but you don't come any further. So I don't know, I've never been in the Bifurcation Club, but the sounds I heard is that they sometimes invite engineers, they maybe we have to invite also engineers, we have to invite maybe other disciplines. For sure we should be motivated, like neurologists, I mean, we should do this in order to get this field moving. If we don't do it and we keep on turning in circles, chasing our own tail, we don't push this field further. So I think that's a negative on this first one, but okay, you have to start somewhere. But I feel like many people are knocking, yeah, we should be open for other disciplines. Or do people think, no, it should be that expert? Who believes it's better to keep it more to pure implanters? No, not really. So I think that's something to take for next year. And then how to be different from other LA closure meetings. Yeah, so that's the thing. When we start with this initiative, of course, then you have nowadays these really company-sponsored LA meetings, which I don't personally, as an independent physician, don't like. I mean, it's not a good thing that it moves in that direction. We should, good that the companies do it, but I think it's a bad tendency that it happens, because it's a complete biased meeting. It's not the way we should go. Then we have CSI LA. That's definitely an LA dedicated meeting. It's good, but it's very case and experience-based, so that I feel people expect something indeed different from this, which is good. So that means there is a space for this, and to do it independent, and I hope it can stay independent. And then I think without interaction, that's why you see, I walk in the audience, I think without interaction there is no ELAACC, because it has to be super interactive. Maybe next year we should have more like an open room. We should have active voting systems that everybody really feels like engaged, you know, like, I don't know, it's not a criticism or maybe half one, but I think, yeah, like sitting on a podium and then not seeing the people in the audience, it's not like current 2024 anymore. It's like the 90s. I think we have to move it, modernize it. We have to get it into a modern jacket, and then I think we can get really far. So, or that's a little bit what I wanted to say, or is there any important things that I miss, or, yeah? Ian?
Yeah, I think you missed one word, it's randomization. We need to randomize, and we need to force ourselves to randomize. And we can be a club, and the number one should be, we have to randomize among ourselves. We can set up a database and it will generate some data, it will be interesting, but it will never be evidence-based, and we should force ourselves to randomize. That's my...
Yeah, true. The only problem there is, and that's a bit disappointing if you hear then about the experience with the bifurcation club. They have been very successful in consensus paper, maybe also registries and so, but purely randomized control trials, only 2 in 20, 25 years or something. And the problem is finance, you know, like who finances this? Yeah, if you do the LAA closure, then you put the patient in the registry and that's it. But if you randomize something, that's typically...
The Nordic trials, they could do it. We should take example of...
Yeah, but that's needed some finance of, let's say, €1 million, €1.5 million for a study or something. So you still, I mean, it's not, I don't say it's not feasible. That should be an ambition of this ELAACC. I think it should be an ambition of it, but it's a further hurdle. But I agree, we have enough of single arm data on LAA closure, and it doesn't push our field into the serious, to be taken serious. I agree. We need these, and I fully agree with what you said. But okay, that takes an extra effort, and hopefully we can count there on the support from the companies. I mean, it should be not one or the other. We should help each other in bringing this field further. I mean, if we do these trials with the help of economical support from companies, this brings the whole field further, and the companies will also benefit from it. I hope they see it that way too. So. But okay, that's something in the future to work on, and that's the whole goal of this ELAACC, and hopefully we're still having this in 20, 25 years as well from now, and in a very successful editions, and with a generation of quite a lot of good data, fun, and consensus papers and all that, but especially also fun and good interaction and social interaction, yes? So that was it for the first day, yes? And I think now the fun part can start, the social part, and tomorrow there's a whole program still, so, okay.